Hi, everyone. Thank you for joining me on this presentation on cancer pain management. My name is Olivia Sutton. I'm an attending in chronic pain and anesthesiology at Brigham and Women's Hospital in Boston, and I'm happy to have you all here with me today. Before we get started, I have no disclosures. And let's begin. So if you ask an AI image generator, this is what it thinks cancer pain looks like. So our goal today is to define cancer pain a little bit better than this nebulous blob crab and build an in-depth understanding of how cancer pain can be managed effectively, especially through advanced interventional techniques that go beyond conventional pharmacologic options. So first, we'll review what cancer pain is, its types, and the impact it has on patients. Second, we'll look at traditional approaches to cancer pain management, discussing where they can fall short, especially for patients with severe or chronic pain. And third, we'll dive into interventional therapies, focusing on the techniques used to manage cancer pain, where these therapies are appropriate, and the outcomes they can provide. So cancer pain is a very broad topic. And when we talk about cancer pain, we are referring to two main subtypes. Pain as a result of the tumor itself. This can be excruciating visceral pain, as commonly seen in pancreatic cancer or somatic pain, such as that due to bony extension or neural impingement. And then also pain as a result of cancer treatments. So chemotherapy, radiation therapy, surgeries to treat cancers, all can cause secondary pain. Even more so, these treatments can cause secondary conditions like nausea, weight loss, immunosuppression, all these things, thus making patients more susceptible to other painful conditions. This pain has multidimensional impact, affecting physical, psychological, and emotional well-being. So cancer pain can present in many different ways and affect people very differently, but there are certain patterns that emerge and certain types of pain that are seen again and again in patients with certain cancers and treatments. There's also this secondary element where inflammation and nerve sensitization caused by the tumor's presence or by the treatment itself further increase pain sensitivity. This type of pain can become chronic, resulting in a constant pain experience that seriously impacts the patient's physical and emotional well-being. Though treating the cancer and preventing increased burden of disease is often viewed as the primary medical goal for these patients, the cost in terms of worsened quality of life, in large part due to added pain, often inhibits progression towards this goal. Furthermore, cancer pain doesn't just affect the individual. Family members and caregivers are often impacted as well as they watch their loved ones suffer and often play a role in the treatment of these patients, which can be physically and emotionally demanding. Without effective pain management, patients can struggle to adhere to cancer treatments, which sometimes require complex regimens and a lot of physical and emotional endurance. In some cases, untreated or inadequately treated pain may lead patients to consider ceasing treatment altogether. Thus, managing cancer pain is not just about comfort, but is also crucial in helping patients to continue with and benefit from their cancer therapies. Cancer is unique in that due to the futile nature of the course of some metastatic processes, patients and providers are willing to tolerate more risk and perform or undergo invasive procedures in order to improve quality of life. Pain is a significant issue for many patients experiencing this, affecting 70 to 90% of those in advanced stages. It has been estimated that approximately 2 to 5% of patients with advanced cancer have inadequate control of pain, even with systemic analgesics. But it isn't just patients with active severe cancer. Even a third of patients who have had curative treatment in the past experience chronic pain during the remainder of their life. These patients may alternatively benefit from interventional techniques such as neuraxial analgesia, minimally invasive procedures for vertebral pain, sympathetic blocks for abdominal cancer pain, peripheral nerve blocks, and percutaneous cordotomies. But before getting to that step, there are many other non-invasive approaches that should be considered the foundation of a comprehensive multimodal approach. The basic framework for how to address cancer pain has been historically the WHO, World Health Organization, three-step ladder for cancer pain management. The ladder represents a clinical strategy for classifying the available analgesics and guiding initial analgesic selection based on the severity of the patient's pain. If mild, which is considered 1 out of 10 to 3 out of 10 as a generalization on the numeric pain scale, the analgesic should be initially chosen from step 1, which includes NSAIDs, acetaminophen, and steroids, especially for nociceptive pain. If the pain is moderate, or 4 to 6 out of 10, or severe, one can start with the step 2 analgesics, which includes the quote unquote weak opioids, such as tramadol, oxycodone, and hydrocodone. And if severe, or 7 to 10 out of 10, one can start with a step 3 opioid, including fentanyl, methadone, or hydromorphone. So at any step, adjuvant analgesics can and should be added to optimize pain control, especially to support the treatment of neuropathic pains. These may include neuropathic agents like gabapentin or pregabalin, SNRIs, anticonvulsants, TCAs, topical agents, etc. The WHO ladder alone is found to be effective in 70 to 90% of patients. And use of all of these agents, as well as optimizing dosing, adverse effects, including overdose risks, that could all be a lecture in itself. But in the interest of time, I want to shift our focus to the next step beyond medical management. Interventional therapies include a range of procedures, from more minimally invasive injections to more complex surgical techniques. The main types we'll cover today include nerve blocks, neurolytic blocks, epidural and intrathecal drug delivery, radiofrequency ablation, spinal cord stimulation, and vertebroplasty or kyphoplasty. The key benefit of interventional therapies is that they work directly at the source of the pain, which can provide long-lasting relief and, in many cases, reduce the need for these systemic pain medications. By reducing the reliance on high doses of opioids and other medications, we can improve patients' quality of life, thus minimizing the burden of these medication side effects and hopefully offering more sustained pain control. There's no clear-cut consensus for when to use interventional therapies in cancer pain, but the rule of thumb is typically to start with the conservative and progress to low risk and then more invasive, high-risk procedures, which are justified in severe refractory pain, as with most things. Some patients may prefer to avoid systemic therapy or have shorter life expectancies, and thus there are always exceptions to this rule. So starting off, autonomic nerve blocks are one of the mainstays of interventional therapy for cancer pain. The neurolytic blockade of sympathetic pathways at different levels are indicated for patients with abdominal pain with a visceral mechanism, which is a primary contributor to many different cancer pain syndromes. Although this presentation isn't long enough to cover all of these, I do want to go into detail in about at least the most common and most important interventions in cancer pain. So that said, before getting into the specifics of these, we need to think about which patients are and aren't candidates to proceed with some of these blocks. So here are some of the most major considerations. Number one is anticoagulation. Most of these blocks are high bleeding risk, and as our guidelines for stopping anticoagulation should be considered and followed closely. As many cancer pains are also thrombocytopenic or have deranged coagulation at baseline, this should also be weighed when deciding to consider these blocks for a patient. Number two is the infection risk. Many cancer patients are immunosuppressed, and especially in these immunosuppressed patients, post-injection infection seeding is a significant consideration, especially in neuroaxial procedures where seeding the epidural or spinal space could be catastrophic. Any potential for systemic or local infection at the injection site should weigh against the benefits. Next, there's also localized tumor is a consideration. There's a theoretical risk of seeding tumor cells into adjacent spaces or the bloodstream if the tumor is traversed with the needle. Thus, review of imaging should be performed prior to scheduling a procedure as well. And then lastly, are there any plans for other future treatments? In cancer patients who may be eligible for palliative or therapeutic chemotherapy or radiation treatments, it may confound the understanding of the effects of the interventional pain procedure or the radiation to perform these at the same time as these ongoing treatments, especially in procedures requiring two potential steps, as we'll go over later. Everything ongoing should be considered when looking at these. So the celiac plexus block. This is one of the mainstays of interventional cancer pain therapy. Alone, celiac plexus block has been found to abolish pain until death in about 10 to 24% of patients. And when used in conjunction with other treatments, 80 to 90% of patients. That's huge. A study in the Annals of Surgery demonstrated significant pain relief at 2, 4, 6 months and a survival benefit in 137 unresectable pancreas cancer patients with significant reduction in morphine usage. And then a systemic review in 2015 concluded that there is strong evidence for celiac plexus block. It provides good analgesic effects and or reduces opioid consumption and some opioid-induced adverse effects in comparison with conventional analgesic treatment. So what are the indications? It can be good for both malignant and benign disorders, but the one that we think of in cancer pain is severe upper abdominal pain due to pancreatic cancer. But chronic pancreatitis can also be treated with this technique in theory. Side effects, it may improve bowel motility, which can be a pro or a con. It may prevent a contraindication if there's the possibility of fixed bowel obstruction due to the risk of rupture. But in patients with this type of pain who typically have been on opioids for a long time, it may actually improve and not truly be a negative side effect. The other side effects include retroperitoneal hematoma, injury to the kidney or the pancreas, pneumothorax, chylothorax, bleeding, sexual dysfunction, and paraplegia due to spasm or injury of the artery of Adamkowitz, which is in the area of the block. So the most appropriate timing for performing the celiac plexus block is still controversial. It was suggested that the celiac plexus block should be performed early, even in the presence of mild pain or in patients receiving low doses of opioids. However, this statement remains unproven. Some authors reported that controlling pain with analgesics and then performing a celiac plexus block can be more effective than an early block followed by pharmacotherapy. In patients with abdominal/pelvic pain who were potential candidates for celiac plexus block, the analgesic treatment with low doses of opioids was effective in all patients. It is likely that the efficacy of celiac plexus block depends on the individual anatomic distribution, which is likely to be distorted with the local progression of tumor. When tumor spreads, involves other somatic areas such as the peritoneum or diaphragm, it may be likely that the block is less successful than in other distributions, as the celiac plexus block can only cover the sympathetic pathways for visceral pain. Pain may worsen due to the involvement of areas outside of the territory dependent on these sympathetic pathways. Therefore, no early procedure may prevent this subsequent neural and somatic structure involvement, which seems to be unpredictable, as found in the current literature. As pain and disease progression are overall understandably unforeseeable, an early block could be disproportionate in many circumstances. But on the other hand, a late block, when somatic structures are already involved or celiac area is distorted, might be more likely to be unsuccessful for those reasons. So thus, the decision on when to perform this should be based on detailed information regarding the patient condition, the aim of the treatment, such as reducing opioid consumption versus opioid adverse effects, and patient participation in the decision-making. So let's talk about the anatomy. The celiac plexus itself is anatomically positioned around the celiac artery and superior mesenteric artery, spanning the T12 and L1 vertebral region. The celiac plexus location is anterior to the diaphragmatic crura and posterior to the stomach. It innervates the stomach itself, the liver, the gallbladder, the pancreas, and the spleen, as well as segments of the large and small intestines. For those of you who remember embryology at all from step one, that represents the foregut and midgut structures. In doing so, it affects many vital physiologic processes, including regulating digestive enzyme secretion, modulating gastrointestinal tract motility, and orchestrating blood perfusion to these organs. It is also a notable conduit for transmitting visceral pain signals from these organs to the central nervous system, and that's what we're targeting. The most common approaches are posterior and anterior para-aortic techniques, although endoscopic approaches can also be performed by endoscopists, offering another approach. The posterior para-aortic approach is the one shown here, and this occurs with the patient prone, with the abdominal support being placed to enhance the thoracic kyphosis. The T12 and L1 vertebral bodies and the inferior border of the 12th rib are initially marked using fluoroscopy, and a skin wheel is created with local anesthetic at the inferior border of the 12th rib, typically 6 to 8 centimeters lateral to the midline. A spinal needle is then inserted at a 45-degree angle. Thus, this can also be done in the Scotty dog view, rotated a bit further to a more exaggerated oblique view, as shown here on the left, aiming at the inferolateral corner of the L1 vertebral body initially, then walking off laterally until the needle moves anterior. Then the fluoroscope is switched to a lateral view, as shown on the right here, and the needle is advanced with a lateral to medial trajectory until the tip is a few millimeters past the anterior border of the vertebral body. After aspiration and contrast injection showing superior-inferior spread along the vertebral body, you can then inject your local anesthetic. The anterior para-aortic approach can also be performed. This is in supine position and particularly advantageous in patients with advanced disease who cannot maintain a prone position or have recently undergone abdominal surgery. However, there is greater risk in this version of the procedure of organ injury, which is the main restriction on its use. So next, for my embryology nerds, the superior hypogastric plexus block is basically the celiac plexus block of the hindgut structures. So this includes the descending and sigmoid colon and the proximal rectum, as well as the pelvic organs, including the uterus, ovaries, prostate, urinary bladder, testes, and seminal vesicles. These are all innervated by the superior hypogastric plexus. A blockade of this prevertebral ganglion may be used to treat persistent or intractable pelvic and rectal pain that has failed conservative treatment measures. So very similar to the celiac plexus block, but for different target structures. The superior hypogastric plexus is located at the confluence of the lumbar sympathetic chains at the anterior aspect of L5 and S1 bodies. The yellow arrow shown here shows a sample needle trajectory used in order to reach this spot, with a goal of reaching the anterior border of L5 on a lateral view between the lateral and midline border of the vertebral body in AP view. So this procedure is typically done bilaterally. The patient is positioned prone and a Scotty dog view is obtained. Further oblique rotation can be used, similar to the celiac plexus block, but in this one, we're limited by the presence of the iliac crest, which can sometimes block that trajectory. The entry point is a few centimeters lateral to the inferolateral corner of the vertebral body, and then advance to contact the corner of that vertebral body. The needle then walks off laterally until it reaches slightly anterolateral to the vertebral body, and then the needle is advanced in lateral until the tip is just past the anterior body border of the vertebral body, as seen in the image on the right. Contrast should be injected then to exclude vascular uptake and look for this same superior-inferior spread, after which, again, we can inject the local anesthetic or injectate. So continuing our path down to the bottom of the sympathetic chain, the distal structures of the pelvis are innervated by the ganglion impar. This ganglion may be blocked to treat malignant vulvar, rectal, and anal pain, intractable sacral and perineal pain, such as in other non-cancerous conditions such as postherpetic neuralgia or coccydynia. Anatomically, it is a midline retroperitoneal structure located anterior to the sacrococcygeal junction, and it is the most caudal ganglion of the sympathetic chain. It provides partial sympathetic innervation to the genitals and pelvic viscera. The most common technique for accessing this space is transcoccygeally due to its efficacy and simplicity. It's a very simple procedure overall, especially in comparison to these other two that we just looked at. You start off by obtaining a lateral view of the coccyx with the patient in the prone position, as shown on the image on the screen. There may be several sacrococcygeal segments that are available to access. And the best option is the one that appears the most open, as if a needle could pass through, and ideally one that doesn't require too inferior of an entry point. The needle is then inserted midline, passed through the sacrococcygeal segment, and landed with the tip just anterior to the bone. Contrast should show spread and again confirm lack of vascular uptake prior to injecting the injectate. All right, so outside of this world of sympathetic blocks, there are other blocks that can target the peripheral nerves to block nociceptive input to the CNS. Nerve blocks are common interventional therapy used to manage cancer pain, especially when the pain is localized to a specific region, area, dermatome, etc. This technique involves injecting anesthetic or other medication around a nerve or group of nerves to block pain signals from reaching the brain. Nerve blocks can be particularly effective for nociceptive pain caused by tumors, which are pressing on or invading the nerves themselves. These can be conducted as simple blocks with local anesthetic to confirm the neural distribution of the pain with a short duration of action. And then steroid could be added to prolong the duration of action and reduce inflammation around the area of the nerves. Many of these, taking it one step further, could also be performed with neurolysis, which involves injection of alcohol or phenol, providing a much longer duration of action. This is commonly done as a second step if the local anesthetic and steroid provided sufficient but short duration relief. The evidence for use of peripheral blocks is limited, but a systemic review in 2015, which was then updated in 2018, demonstrated that most cases did experience pain relief, many of which for several weeks, and there were very few adverse effects. However, none of the trials included were randomized control trials. There are too many of these procedures to go into every single one, but some of the most commonly used blocks are paravertebral blocks, commonly used for pathologic rib fractures and lesions, breast cancer pain, and postoperative pain. Intercostal blocks have similar indications for chest wall innervation by tumor, pathologic rib lesions and fractures, and postoperative pain. And brachial plexus blocks are a family of blocks on their own, which are used especially in tumor invasion of the brachial plexus or lesions within the arm. For patients without focalized pain or insufficient benefit from other interventions, and for whom systemic analgesics are exhausted, neuraxial analgesia may be an important viable option for them. Neuraxial analgesia may contain local anesthetics if there's a localized site of pain that may benefit from that distribution of relief, but commonly opioids are the mainstay of this therapy. Patients with cancer-related pain and longer survival expectancy, typically thought of as greater than 3 months, may benefit from neuraxial therapies using implantable systems with a permanent intrathecal catheter and subcutaneous pump, while patients with a shorter life expectancy may be treated with epidural therapy with an implanted system, such as a catheter or portacath connected to then an external PCA pump. The mechanism of neuraxial analgesia is based on opioid binding to its receptor in the spinal cord, which reduces or blocks the nociceptive signal conduction. Opioids may also interfere with descending pathways and modulate the pain pathway in the midbrain. However, other anesthetic agents, such as bupivacaine, which has a long duration of action and low toxicity and costs, may be used as the main spinal therapy or in addition to opioids. Some examples of other agents commonly used in a mixture with these are clonidine, ketamine, and even neostigmine, which may improve analgesia and reduce opioid doses. Okay, so moving to the next step, percutaneous vertebroplasty and kyphoplasty are minimally invasive procedures indicated for the relief of vertebral bone pain in patients with metastatic lesions and/or compression fracture without neurologic sequelae. Vertebroplasty usually involves percutaneous injection of a cement, polymethyl methacrate, methyl acrylate, into the vertebral bodies, which can provide a mechanical stabilization of the lesion or compression fracture, increasing bone strength and alleviating pain. Kyphoplasty is a variation on these vertebroplasties, and it is performed by inflating a balloon in the vertebral body to make an empty space where the cement can be placed to correct vertebral height and kyphotic irregularities. An updated systemic review in 2018 assessed treatment safety and effectiveness of vertebroplasty and kyphoplasty for treatment of cancer related vertebral fractures and found only 6 RCTs among 150 selected studies. They compared vertebral augmentation with traditional management and treatments for tumor control and found that pain intensity, pain related disability, and health related quality of life improved following kyphoplasty compared to usual care. However, heterogeneity of study designs, outcomes, and populations still suggests that current literature provided inconsistent data, and further studies should delineate confounding variables. Contraindications for these two invasive procedures are similarly coagulopathy, neurologic symptoms by vertebral compression or tumor encroachment on or within the spinal cord, complete collapse of the vertebra, presence of systemic or local infections, and certain types of lesions, such as osteoblastic metastasis. Complications are of concern, as cement leakage was found to occur in 20 to 70% of patients, and cement embolism can be found in as much as 26% of patients. Moreover, symptomatic vertebral fracture may be a common adverse effect after kyphoplasty, but there's actually a higher risk of vertebral fracture after vertebroplasty, more so than kyphoplasty. I just want to take also a brief moment to discuss radiofrequency ablation and cryotherapy lesion for vertebral metastasis. In radiofrequency ablation, bone tumor or metastases are ablated using the heat generated from medium frequency alternating current. Cryoablation is another alternative to radiofrequency ablation in patients with metastatic bone disease, performed using cryoprobes through which cooled, thermally conducted fluids are circulated. As with most procedures of its kind, recommendations for performing radiofrequency ablation and cryotherapy are weak. Further RCTs in patients with cancer-related pain are required to improve the strength of evidence available to recommend these procedures on a large scale. And then cordotomy. Historically, cordotomy was an open procedure, but percutaneous cordotomy by radiofrequency has become a viable choice due to advances on fluoroscopic equipment and the possibility of performing the procedure under sedation instead of general anesthesia, which thus represents an advantage in these potentially fragile patients with advanced cancer. However, this intervention does cause an irreversible disruption of the nervous system conduction, and therefore patient selection should be approached very carefully. The selection of patients with cancer for this procedure is based on presence of malignant unilateral pain, refractory to systemic treatment, and other non-destructive interventions. Life expectancy of a few years or less is usually an important consideration, and considering the possibility of pain recurrence as these lesion nerves may regrow and neuropathic pain may return, and also the anatomic location of the intervention occurring in an area that permits a safe procedure. It is recommended that treating unilateral pain caused by pathologies such as malignant pleural mesothelioma, breast cancer, brachial plexus pain related to Pancoast tumor pressure or infiltration, or unilateral leg pain are possible considerations for this treatment. This treatment can also be used in bilateral cancer-related pain, but bilateral interventions do increase the risk of complications and mortality. So, performing it itself, the percutaneous cordotomy is a thermal lesion caused by radiofrequency electric current in the spinal thalamic tract, contralateral to the side of pain, interrupting conduction fibers and selectively eliminating pain and temperature sensation from the affected half of the body. Its overall mechanism is not completely clear, but alteration on descending impulses and dorsal horn modulation, damage of these C nerve fibers, and a modulatory, immunomodulatory effect may all play a role on pain transmission. Radiofrequency lesions may be done at several sites, but the main entry point is located over the C1 to 2 intervertebral foramen on the opposite side of the source of pain and may be only suitable to treat pain below the level of the C4 dermatome. Retrospective and uncontrolled studies that have been done thus far do suggest that percutaneous cordotomy is effective in reducing pain and also in decreasing or discontinuing opioid use. However, there is a lack of controlled studies, as with most, and very few recent prospective studies about the effects of this treatment in cancer related pain, as demonstrated by the limited number of case studies and case series, as well as narrative and systemic reviews. Contraindications, as with most, abnormal coagulation is a contraindication, infection, severe respiratory dysfunction, and advanced disease that hinders even positioning the patient correctly for the procedure. I did mention bilateral cordotomy procedures. Typically, this is not recommended at the high cervical region due to risk of respiratory depression, and thus midline structures or bilateral pain are also not ideal for this procedure, although not officially an absolute contraindication. Possible complications from the procedure itself include hemiparesis, respiratory irregularities, bowel and bladder dysfunction, which admittedly are usually temporary, and ataxia. Thus, it should really only be performed when the pain is truly severe and all the conservative analgesic options have been exhausted. All right, so in conclusion, there are many interventional therapies available to pain physicians when systemic analgesics are insufficient or limited by side effects. But careful patient selection, rather, is of utmost pertinence, and the benefits should outweigh the risks of these procedures, requiring a thorough knowledge of the limitations and side effects. Lastly, there's still a need for randomized controlled trials to better investigate the efficacy and side effects of these procedures. So, thanks to all for listening.